This presentation is going to review alterations of hormonal regulation. This slide should be familiar to you. It's the same one from last week regarding the different hormones that are responsible for the alterations in our body and the glands or organs that are associated with them. So please take a minute to reorient yourself on these hormones, glands, and organs. This week will be a little bit different than last because we're going to be talking about the mechanisms of hormonal alterations and then going over disease processes where there will be alterations of hormone alterations. So first, let's talk about the mechanisms. We have number one, abnormalities in endocrine function that can be caused by either a hypersecretion or a hyposecretion of these hormones, or it could be an alteration in how they're being transported, so through transport molecules. Number two, endocrine abnormalities may also be caused by the alterations in receptor function through a variety of mechanisms. So there's 4 different possibilities. It could be that there's a decrease in the number of receptors, or the receptors are insensitive to the hormone. The presence of antibodies against specific receptors are present. And lastly, there could be defects in the second messenger generation or post-receptor defects. We also have abnormally high levels of circulating hormones that are sometimes caused by the release of these hormones from tissues outside of the endocrine system. So there could be an ectopic focus instead that may not respond to the normal feedback mechanisms in which our body is accustomed to. And in these cases, they're said to be functioning autonomously. Well, what happens when there's significant elevation or depression of hormone levels? You can see here in this box what can happen if we have inappropriate amounts of hormones delivered to specific target cells or inappropriate responses of the target cell. Dysfunction of an endocrine gland may involve that gland's failure to produce enough of that biologically free or active hormone form. We call this hyposecretion because there's an inadequate amount. The failure may occur when secretory cells are unable to produce or even obtain an adequate amount or quantity of the required hormone precursors, or when they're unable to actually convert the precursor to the active form of that hormone. But once a hormone's released into the circulation, they could also be degraded at the altered rate or inactivated by antibodies before they can reach the target cell. So there's an interruption of that hormone. Other causes of decreased hormone delivery could be because of inadequate blood supply to the gland or target tissue, or it could be an abnormal amount of appropriate carrier proteins within the serum. A gland can also synthesize or release too much hormone or excessive amounts. We call this hypersecretion of the hormone. So think about the feedback systems that we talked about last week. They need to recognize the need for a particular hormone, but this recognition can fail to function properly, or it can respond inappropriately to these signals. Whenever there's an ectopic source of hormone, remembering that means it's not produced by endocrine tissue, it can result in an abnormally elevated hormone level without any benefit of the normal feedback system, which helps to control the hormone. And in these cases, those ectopic hormone production situations, we're saying that they're working all by themselves, right? So again, the word that we use is autonomous, and there could be alterations in the expression and the function of hormone receptors as well. So it's going to overall affect the hormone action. The target cells may fail to appropriately respond, so they become insensitive. And generally, there's 2 types of target cell insensitivities to think about. So it's either the cell surface receptor associated disorders or the intracellular disorders. So first we're going to talk about the cell surface receptor associated disorders. These disorders are identified primarily in water-soluble hormones like insulin, and they involve a decrease in the number of receptors leading to a decrease or defective hormone receptor binding ability, or the impairment of receptor function, which will result in the insensitivity of the hormone. But also that presence of antibodies can reduce the available binding site, or it can mimic hormone action, which would suppress or exaggerate that target cell response. Lastly, unusual expression of receptor function can occur in some tumor cells as well. So those are examples of cell surface receptor associated disorders. But what about the intracellular disorders? They have acquired defects in post-receptor signaling cascades or inadequate synthesis of the secondary messenger, such as CAMP. Remember, cyclic adenosine monophosphate. They're needed to transduce a hormonal signal into an intracellular event. The target cell for water-soluble hormones, they have faulty responses sometimes to hormone receptor binding. And when they do, they're going to fail to generate that required second messenger that's needed for the cell to have an abnormal, to have a normal response. So therefore, we're going to have an abnormal response to the second messenger, especially if levels of the intracellular enzymes or proteins have been altered. The target cell will fail to express that usual hormonal effect, and we won't see what was expected. Pathogenic mechanisms affect target cells as well for lipid-soluble hormones such as the thyroid hormones or glucocorticoids. These are recognized less often though because they're affecting the water-soluble hormones. But when they occur, the mechanisms are very similar to those for the water-soluble hormones. You're going to see changes in the number, changes in the binding affinity to the intracellular receptors. You're going to have also altered generations of new messenger RNA. In other cases, hormone responsiveness can also be linked to alterations in the co-regulators, the transcription factors, and the proteins of your DNA. And these are the ones that are supposed to facilitate or inhibit the transcription of the target gene. So there are pathogenic mechanisms as well. Our first focus is going to be on the alterations of the hypothalamic pituitary system. If our pituitary gland, specifically the anterior pituitary gland, is not working correctly, we may have the hypersecretion of growth hormone. And this is called giantism or acromegaly. We call it giantism if the growth hormone hypersecretion is occurring in children and adolescents, but most often it's going to occur as acromegaly in our older adults. Not too old, but like anywhere between 40 and 60 years old. And often it's already been there, it's been present before the diagnosis was made. But because of the insidious nature of the disease, you might not have caught it. But consequently, since the diagnostics are later, you might already have systemic complications like heart disease, secondary to hypertension, coronary artery disease, stroke, diabetes, and malignancies like colon and lung cancer. Therefore, there is increased mortality and premature death associated with acromegaly. The pathophysiology itself has to do with this growth hormone secreting adenoma. When there is that growth hormone secreting adenoma, the usual baseline secretion patterns are kind of crazy and the peaks are lost. However, the growth hormone levels in patients with acromegaly are never really completely suppressed, but you might see slight elevations that are showing the stimulation of growth. In children and adolescents, or those patients where the epiphyseal plates have not yet closed, the effect of increased growth hormone will cause excessive skeletal growth, and some patients will actually become 8 to 9 feet tall. We call this again giantism, because that growth plate, our epiphyseal plate, hasn't closed. We have the tendency for that. But in adults, that epiphyseal plate is already closed. So when we have increased amounts of growth hormone, we're seeing the changes in the connective tissue. The connective tissue proliferation, the increased cytoplasmic matrix will change the characteristics of our patient, as well as bony proliferations that will result in these very characteristics of appearance features of patients with acromegaly. With the connective tissue proliferation, you might note on your patient an enlarged tongue. They may experience interstitial edema, increase in the size and function of the sebaceous and sweat glands. Their skin may feel very coarse, and they may have a lot of body hair. The bony proliferation has to do with large joint arthropathy. They may experience kyphosis, enlargement of facial bones and hands, as well as their feet. Their jaw may look like it's protruding forward, as well as their forehead, and there may be a need for increasingly large shoes, hats, rings, gloves, because their bones are so large. In terms of diabetic symptoms, your patients with acromegaly may experience polyuria and polydipsia as well. And this is because of the decreased insulin sensitivity in patients that can't make enough compensatory hyperinsulinemia. Acromegaly-associated hypertension is usually asymptomatic until heart failure symptoms develop as well. And this increased tumor size can result in central nervous system symptoms like headache, seizure activity, and visual field disturbances as well. They may even have papilledema. Now, if this compression hypopituitarism occurs, gonadotropin secretion can be affected. And this can cause amenorrhea in our women with acromegaly and sexual dysfunction in our men with acromegaly. Patients with acromegaly sometimes will also have hyperprolactinemia. It happens in about 40% of these patients. And what you'll notice is changes in genes as well that has to do with somatostatin receptors and GTP binding of the G protein receptor mutations. So how then do we evaluate and treat our patients? Well, though you're going to learn more about this in MedSurg, I want you to know that diagnostic really is confirmed by the appearance of the clinical features of the disease. And there may be testing of the eyes. You might have an MRI scan, but it can also be detected by elevated levels of IGF-1, and GH levels are typically elevated and not suppressed with oral glucose tolerance testing. That's a way that you can figure this out as well. And the goals of the treatment is really to try to normalize these hormones as best you can within the age range so that you can restore normal pituitary function. But again, remember that most of the time when these diseases, giantism or acromegaly, are diagnosed, it is advanced because the symptoms were so insidious and you may not have noticed for some time. This next disease process is a disease of the posterior pituitary, and they can cause abnormal secretions of antidiuretic hormone, sometimes called vasopressin. And this is an excessive amount of hormone that's going to result in water retention and a hypoosmolar state. So remember when I was talking about ADH hormone last week in terms of how it can concentrate our urine, so we're not producing a lot of volume, but we're getting rid of the waste. Well, when we have the disease of the posterior pituitary and with syndrome of inappropriate antidiuretic hormone, we're having a secretion that's characterized by high levels of ADH in the absence of normal physiologic stimuli for its release. And the common cause of SIADH is ectopic production of ADH by tumors, like a small cell carcinoma on the duodenum, the stomach, and the pancreas. Also, cancers related to the bladder, prostate, endometrium, lymphomas, and sarcomas can also trigger the syndrome of inappropriate antidiuretic hormone, or SIADH. There are some pulmonary disorders associated with SIADH as well, like pneumonia. And it has been seen that SIADH can produce central nervous system disorders, the central nervous system disorders that can cause SIADH symptoms, like encephalitis, meningitis, intracranial hemorrhage, tumors, and even traumas and neurosurgery can trigger a patient in this state of SIADH. We also know that patients with respiratory failure that require mechanical ventilation, asthma patients, cystic fibrosis patients, they can also trigger SIADH as well. The precise mechanism is really uncertain on why this could happen sometimes after surgery. And when it happens after surgery, we call this a nephrogenic form, which involves an X-linked mutation in the AVP gene that leads to chronic activation of the tubular V2 receptor. All of that to say, it's going to result in excessive free water reabsorption in concentrated urine. Lastly, we have transient SIADH. This is especially common after pituitary surgery because stored ADH is going to be released in an unregulated fashion after the surgery. So medications are important as well, because especially in our older patients, they can cause SIADH, and they include hypoglycemic medications, antidepressants, antipsychotics, narcotics, general anesthetics, chemo agents, non-steroidal anti-inflammatory drugs or NSAIDs, and also synthetic ADH as well. And they can stimulate ADH release, enhancing the physiologic effects of ADH, or they have a biologic action that's very similar to natural ADH that's found in our body. So let's talk about the pathophysiologic features of the symptoms that are associated to SIADH. In a very compressed way of saying this, it's really the result of enhanced renal water retention. ADH increases renal collecting duct permeability to water by inducing the insertion of aquaporin 2. This is a water channel protein in the tubular luminal membrane, which will then increase water reabsorption by the kidneys. This results in an expansion of extracellular fluid that leads to dilutional hyponatremia, meaning you're going to have very low sodium concentrations in your blood. You're also going to see hypoosmolality and urine that's inappropriately concentrated with respect to the serum osmolality, because the water is reabsorbed, and the water that is being reabsorbed, this would have been excreted. So again, the increased permeability of water is due to more aquaporins. You're going to have water reabsorption by the kidneys, more extracellular fluid leading to dilutional hyponatremia. So the symptoms that you're going to see are symptoms of having low sodium. You may also have impaired taste, thirst, anorexia, dyspnea on exertion, fatigue. You might even have peripheral edema, but usually that's not going to be as prominent. When you have these symptoms, it's usually when you have serum sodium levels that are decreasing rapidly from 140 to 130. You also might note GI symptoms like vomiting, abdominal cramps, and these occur when sodium concentrations are even lower, 130 to 120. There's going to be weight gain from water retention even when your patient has nausea and vomiting, and it's because of that movement of fluid to the extracellular space. And even if hyponatremia develops slowly, the serum sodium levels less than 110 to 115 will cause confusion, lethargy, muscle twitching, and seizures. And sometimes with sodium levels that low, you can have irreversible neurologic damage that can occur. When you correct the hyponatremia, most of these symptoms can resolve with that correction of sodium. So the main diagnostic feature then, or monitoring tool, is really to monitor the serum osmolality, hyponatremia levels, and the urine hyperosmolality levels as well. Other things that you can do is look at urine sodium excretion, maintain normal renal, adrenal, and thyroid function, and you're checking for the absence of other conditions that could alter the volume status of your patient. So think about things that have to do with fluid, like diuretic use, heart or liver failure, hypervolemic shock, or renal insufficiency. ADH is difficult to measure in the serum. Okay, so instead, copeptin, which is an ADH precursor molecule, can be used instead to check. And individuals that have neurologic injury because their hyponatremia has gotten so low, so remember 110 to 115 is severe, this can be caused by cerebral salt wasting syndrome. And this can be differentiated from SIADH because with cerebral salt wasting, it's characterized by hyponatremia, hypovolemia, and weight loss. In addition, urine sodium levels are elevated. So again, make sure that you can differentiate the difference between the neurologic conditions associated with SIADH and cerebral salt wasting. So I'll say it one more time. Individuals with neuro injury can also develop low sodium, but this is due to cerebral salt wasting syndrome. And the way we tell the difference is because cerebral salt wasting syndrome is characterized by hyponatremia, hypovolemia, and weight loss. In addition, their urine sodium levels are going to be elevated. You're going to get into the treatment of SIADH more in med-surg, but remember, if you can correct the underlying cause, which is the low sodium, then most of the time you can correct some of these symptoms. Diabetes insipidus is the insufficiency of ADH that leads to polyuria or frequent urination. Your patient may also experience polydipsia, where they are very thirsty. There are two forms of diabetes insipidus, neurogenic or central. This is also called hypothalamic. Or you can have nephrogenic or renal type of diabetes insipidus. So first, let's talk about the neurogenic or central diabetes insipidus. And this is caused by an insufficient secretion of ADH. When there's some type of organic lesion of the hypothalamus or somewhere on the pituitary stalk or posterior pituitary, it's going to interfere with the synthesis of antidiuretic hormone or the transport of it or the release of ADH. And these lesions are primarily things like metastatic brain tumors, aneurysms, thrombosis, infection, or even immunologic disorders as well. And neurogenic diabetes insipidus is very complicated, and it can be in a result of a traumatic brain injury or pituitary surgery, where diabetes insipidus is either transient, but it also can be permanent as well. We also can see neurogenic DI as a complication of pregnancy. In rare cases, It can be caused by hereditary disorders that affect the ADH gene, or it could be a result in the structural changes that happen on the pituitary gland. Pathophysiologically, we're going to see that it's caused by the inadequate response of the renal tubules to ADH, and it's usually acquired or can be genetic. Disorders like pyelonephritis, destructive uropathies, polycystic diseases, and intrinsic renal disease, they all can lead to irreversible types of diabetes insipidus. Also, drugs that induce a reversible form, a nephrogenic diabetes insipidus, it includes lithium, colchicine, which is used for patients that have gout, amphotericin B, loop diuretics, and general anesthetics can cause a nephrogenic form of DI. Now, acquired nephrogenic DI is generally related to the disorders and drugs that damage the renal tubules and inhibit the generation of CAMP in the tubules. We also have gestational DI, which is rare, but it can be associated with pregnancy. In this case, the level of vasopressin degrading enzyme is going to be increased, meaning that it's going to degrade the production of ADH. And the clinical manifestations are usually mild and they don't really require much treatment. Individuals with diabetes insipidus have a partial to total inability to concentrate urine. When you have insufficient ADH, this is going to cause large volumes of dilute urine, leading to increased plasma osmolality. In conscious patients, the thirst mechanism is going to be stimulated and it will induce polydipsia, and usually it's a craving for something cold to drink. Dehydration develops rapidly without ongoing fluid replacement. So if your patient has these cravings, they need to consume this water. If the individual with DI can't conserve as much water as they're losing in their urine, meaning that their input can't match or keep up with their output, then you're going to notice serum hypernatremia and hyperosmolality is going to occur. Generally, concentrations of the other electrolytes aren't going to be affected. So remember, if you can't make ADH, then you can't concentrate urine, meaning you're going to have a lot of volume. So they're going to pee a lot. Your patient's manifestations are going to include polyuria, nocturia, continuous thirst, and polydipsia. Okay, and that urine output is going to vary, but usually it's increased from their normal output. Individuals that have diabetes insipidus for long times may develop a large bladder capacity, and therefore it starts to degrade their their urologic anatomy as well. And it could cause hydronephrosis because of that increased pressure and large content in the bladder that could put pressure back into the kidneys. With neurogenic diabetes insipidus, usually it has an abrupt onset, and many people can actually recall the exact date and maybe even time which they're starting to recognize their symptoms. But with nephrogenic DI, the difference there is that there's going to be a more gradual onset. To treat DI, usually you're just trying to rule out any other type of urologic disorders that may cause low urine specific gravity, low urine osmolality, hypernatremia. So you're looking for things like that, like diabetes would be a differential. But the first step to diagnosing a patient with diabetes insipidus is using water deprivation as a measurement of serum osmolality and plasma ADH levels. If you deprive water, this could be a useful test because if your patient has DI, they're going to respond with a rapid decrease in urine volume and an increase in urine osmolality. But with those, if they don't have diabetes insipidus, right? Then their urine volume is going to go. But if you deprive someone with diabetes insipidus, it doesn't even matter, because you may be depriving them with water, but their urine volume is going to be the same, and there could still be an increase in urine osmolality, because it's the hormone level that's causing the increased volume, not the amount of water that they are consuming. In patients with severe DI, testing them like this, doing this water deprivation test, can be hazardous, and it's not recommended. But I just wanted to highlight that so you can understand the difference. And just like the last disorder, SI-ADH, we can't really test ADH. It's not a good way to test the level. There's not a good way to test that ADH level in the plasma. So we can use copeptin, which is that precursor molecule, and we use that as a surrogate to measure ADH secretion. So it also can be a diagnostic as well, but again, most of it is just ruling out the other things. Now, treatment for nephrogenic DI, this is going to be based on the extent of ADH deficiency, how old they are, their cardiovascular status, lifestyle, endocrine status, and all of that as well. And so some of these patients are going to require the replacement of ADH, but fluid replacement using oral or intravenous routes is usually adequate to helping patients with nephrogenic DI. If you need a ADH replacement, we have synthetic vasopressin analog, which is called DDAVP or desmopressin, and you can prescribe desmopressin to these patients. Let me give you another example to help you understand this insufficiency of ADH. When you have a patient that maybe is like 5 or 6 years old and they're persistent bedwetter, and you've tried everything, you've ruled out constipation. Yes, that is an etiology for bedwetting as well, so you can look that up. But let's say you've tried everything. Well, it could be that they just have low amounts of ADH and their body just has not produced enough yet as they're getting older and mature. Well, if they don't have enough ADH, sometimes what pediatricians will do, which I don't recommend, but they do this, they will prescribe DDAVP or vasopressin or desmopressin, excuse me. And this is a medication that they'll take in very small quantity with just a little sip of water at night before bed. And what this will do will replace that ADH that they don't have. So they'll have that antidiuretic hormone so that they're not causing a lot of urine volume during the night, which in theory should help with the bedwetting. Okay, so that's an example of ADH and the insufficiency, and then using ADH replacement to get the result that you want. This table here does help you to balance and differentiate the signs and symptoms of DI versus SI-ADH. Please know the difference because they are completely opposite. With DI, you are going to have lots of urine because you don't have enough antidiuretic hormone. With SI-ADH, there is too much. So you're going to have low urine output. You can see the difference in urine osmolality, specific gravity. You see with serum sodium, SI-ADH, you'll have symptoms of hyponatremia versus DI will be hypernatremia. And the same thing with the hyperosmolality in DI or the hypoosmolality in SI-ADH. So what are the overall symptoms? With DI, diabetes insipidus, because you will be not able to concentrate due to not having enough ADH, you're going to have polyuria, thirst, high urine output, and signs of dehydration. But with SI-ADH, you're going to have opposite. Your patient is going to retain water. There's not going to be enough urine output. They may feel nauseated, they may vomit, and they might experience mental changes when there's very low levels of sodium. The next focus is the alterations of thyroid function. When someone is said to be hyperthyroid, this means that their T3 level is high, their T4 level is high, but their TSH is low, or thyroid stimulating hormone. Hyperthyroidism is the primary elevation in thyroid hormone, but TSH is secondarily decreased. With hypothyroid patients, they have a low T3 and T4, and therefore their feedback loop is going to be that their thyroid stimulating hormone is increased. The TH level is decreased due to the condition that's affecting the gland, or they may not have the gland at all due to a surgery. Maybe they had hyperthyroidism and then they took the gland out, or there was a malignancy. Well, then TSH is going to be elevated in response. You may have subclinical and congenital forms of hyper and hypothyroidism as well. Subclinically, you might see elevations in TSH levels with normal TH. So you don't really see many of the signs and symptoms as well. Congenitally, you might not even notice until about 4 months without proper screening, but the patient may seem like they're unable to eat. We're talking about babies here because we're talking about congenital reasons. They might have a very hoarse cry, protruding tongue, and this is caused by the myxedema of the oral tissues and the vocal cords. Patients may experience constipation. They may have temperature instability, cold skin, slow heart rate. Everything is really low, and usually if it's congenital, it's a congenital hypothyroidism. Now, disorders of thyroid function develop as a result of a primary dysfunction or disease of the thyroid gland, or secondarily, it's a result of the pituitary or hypothalamic alterations. The primary thyroid disorder results in alterations of the TH or thyroid hormone levels, and this is with a secondary feedback effect on the pituitary TSH level. So that's why you see the inverse of the T3 and the T4. So again, for an example, with primary elevations in thyroid hormone levels, then the THS levels are secondarily going to be decreased because of that negative feedback. But when those TH levels are decreased, so I'm talking about T3 and T4, then because of the condition affecting the thyroid gland, your feedback loop is going to say TSH levels need to be elevated in response. Now, thyroid disease can also present with no or minimal symptoms, and you might not even detect any abnormal labs as well. Okay, again, this is called subclinical. First, we're going to talk about hypothyroidism, and this is connected with myxedema coma. First, let's talk about this condition. It's going to cause your T3 and T4 to be low. Okay, so when we say hypo, the low is the thyroid hormones. It's T3 and T4. But because of that feedback loop, again, TSH is going to increase in response. You may also have low iodine. Now, hypothyroidism results with this deficient production of TH. Or again, if you don't have a thyroid gland anymore due to surgery, or and that could be from previous hyperthyroidism or a malignancy or growth. It can be primary or secondary, but primary hypothyroidism really accounts for 99% of all cases. Now, secondary hyperthyroidism, that would mean like the 1% that may have had some type of pituitary or hypothalamic failure, or the gland was removed. The pathophysiology has to do with the loss of thyroid function in primary hyperthyroidism. We're going to talk about that first. This is leading to a decreased production of TH. Again, feedback loop, increased secretion of TSH and TRH as well. Now, the most common causes in adult is autoimmune thyroiditis, and sometimes this is called Hashimoto's disease. Okay, it's autoimmune. We will see an iatrogenic loss of thyroid tissue that can occur also after surgical or radioactive treatment for hyperthyroidism. We also might see an iatrogenic loss due to head and neck radiation therapies, medications, or it could be endemic iodine deficiency that occurs too. Now, infants and children, they may have hypothyroidism, but it has to do with the congenital defect instead. Let's talk about the central pathophysiology. With central or secondary hypothyroidism, this is because the pituitary fails to synthesize enough TSH, or they lack TRH to stimulate TSH, right? And so pituitary tumors that compress the surrounding pituitary cells, also the consequence of having the treatment of these tumors can put you into a secondary hypothyroidism state. Other things like traumatic brain injury, a subarachnoid hemorrhage, or pituitary infarction can cause hypothyroidism that is secondary. Hypothalamic dysfunction results in low levels of TRH, TSH, and TH. So we're going to see all three being very low. Now, subclinically, you might see very mild symptoms or no symptoms at all. So, what are the characteristic signs of very severe or long-standing hypothyroidism? That's myxedema. And with myxedema, you're going to see an altered composition of the dermis and other tissues. The connective fibers are going to be separated by increased amounts of protein and mucopolysaccharides. And this protein mucopolysaccharide complex will bind to water, producing non-pitting boggy edema, especially around the eyes, and we call that orbital edema. They'll have it on their hands, their feet, their subclavicular fossae, their tongue. So you'll have that protruding tongue. Laryngeal and pharyngeal mucous membranes will start to thicken, producing very thick, slurred speech and also hoarseness. For patients that have severe hypothyroidism and they're not being treated, it's very difficult sometimes for them to talk because of these changes on their mucous membranes and their tissues. If they get into a state of myxedema coma, this is a medical emergency. You're going to see diminished levels of consciousness that's associated with severe hypothyroidism. And most individuals can get into a state of unconsciousness. Also, though, they can be conscious as well. And the precipitating events that could put your patient that has hypothyroidism into this severe hypothyroidism level could be infection. Maybe they decided to stop taking their thyroid supplements, or they can't afford it, or they lost it. Also, the overuse of narcotics or sedatives can also put them in severe hypothyroidism. And it could be a consequence of having another acute illness. So if you have a patient with hypothyroidism and they are taking supplements, please encourage them and teach them about myxedema coma and the effects, because it is a serious condition. Other individuals with comorbid conditions like a pulmonary or urinary tract infection, CHF, cerebrovascular accidents, or untreated hypothyroidism are going to be at particular greater risks. And the signs and symptoms that you might also hear about are hypothermia without shivering, hypoventilation, hypotension, hypoglycemia. They could be in a state of lactic acidosis and coma. Symptoms of hypothyroidism in older adults should not be attributed just to normal aging changes, because you might see that they're having difficulty with some of these things. And if you didn't know that it had to do with their thyroid, it might just get mistaken for being older. The evaluation and the treatment, the diagnosis of primary hypothyroidism, it's usually because of the symptoms, and then you're checking the thyroid levels. Of course, if their hormone levels are low, you're going to have patients on hormone replacement therapy. And this is with the hormone of levothyroxine. This is the treatment of choice for hypothyroidism. For patients with subclinical hypothyroidism related to elevated levels of TSH and clinical symptoms, you can also, just watch to see if there are any clinical symptoms. If they are, then you can treat accordingly. But if not, the provider may decide not to treat quite yet. The restoration of normal TH levels is to be the most important thing. It has to be timed appropriately, and also it depends on their age, their sensitivity to the medication, and the severity of their hyperthyroidism. Also, keeping in mind, presence of other comorbidities, particularly cardiovascular disorders. Now, pregnant women need to be evaluated for thyroid function, because if they have low levels of thyroid hormone, then their baby will also have low levels, and they may be born with congenital hypothyroidism as well. Now, the treatment of myxedema coma with thyroid hormone can be used in combination with circulatory and ventilatory support, especially if they are in a coma, and you're going to have to manage hyponatremia and hypothermia, low temperature, and cold internal temperatures. And this is usually going to be effective with that patient. With hypothyroidism, there's something else to know. Again, this is the autoimmune disorder, Hashimoto's disease. And this is a primary hypothyroidism issue, and it has to do with iodine deficiency. And it's the most common cause worldwide of hypothyroidism, and this is also in the US as well. And what you're going to see is a gradual inflammation and destruction of the thyroid tissue, where the thyroid autoantibodies will infiltrate, and you're going to see reactive T lymphocytes, natural killer cells, inflammatory cytokines, leading to apoptosis, which eventually will cause the destruction of the tissue and iodine deficiency. We also have something called subacute thyroiditis, which is also called de Quervain's thyroiditis, and this is an uncommon non-bacterial inflammation of the thyroid, often preceded by some type of viral infection first, and it's accompanied by fever, tenderness. Your thyroid will look enlarged. There'll be a inflammatory process that initially will result in elevated levels of thyroid hormone first, caused by the release of the stored thyroglobulin, which is a transient hypothyroidism that's happening until your gland recovers to normal activity. These thyroid antibodies aren't present in the blood, so sometimes it's hard to test for, and symptoms may last 2 to 4 months. You might use NSAIDs or corticosteroids to resolve the symptoms as well. Most of the time it is painless, but sometimes there can be some irritation as well. Postpartum thyroiditis, this is related to Hashimoto's also. And generally, it's going to last up to 6 months after the delivery. So first, you're going to have a phase of hyperthyroidism, which precedes the hypothyroid phase. And they will be seen, this postpartum thyroiditis will be subacute, painless. Sometimes it doesn't recover as quickly, but 95% of the time it's going to recover pretty quick. And then we talked about congenital hypothyroidism already, but I'll just note just one more thing about it. It is an abnormality that occurs in about 1 to every 4,000 live births. So it's worth testing for. Now we're moving on to hyperthyroidism. And something to note is a term called thyroid storm. And if you do not fix the thyroid storm, you can actually have a patient die within 48 hours without treatment. And so that treatment can include beta blockers, methimazole, steroids, propylthiouracil, and iodine. But sometimes it can be spontaneous. It's often associated to Graves' disease, which we're going to talk about right now. Sometimes it can be precipitated by stress, infection, pulmonary cardiac disorders, trauma, surgery, and emotional stress as well. So with thyroid toxicosis or hyperthyroidism, the pathophysiology has to do with an increased amount of thyroid hormone levels, so T3 and T4. And hyperthyroidism is a form of thyroid toxicosis. And this state, you're going to have excessive amounts of thyroid hormone secreted from the gland. That term, thyroid toxicosis and hyperthyroidism, are often used interchangeably. I'm going to use hyperthyroidism. The prevalence of hyperthyroidism is up to about 2.1% in the US, and about 0.7, which is less than 1%, is subclinical. More prevalent in women than men, and in iodine deficient geographic areas, you're going to see more of this hyperthyroidism. Now, thyroid hormones are regulated by that negative feedback loop, right? And it involves the hypothalamus, pituitary gland, and your thyroid gland. And so common diseases that will cause a primary hyperthyroidism, this is Graves' disease. And with Graves, you have multinodular goiter, and it can be toxic. And also, it can involve a solitary toxic adenoma as well. It's rare that it's from a thyroid carcinoma, but it can happen. Now, secondary hyperthyroidism is a little bit less common, and it has to do with TSH secreting pituitary adenomas. Hyperthyroidism isn't associated thyroid toxicosis isn't associated with the hyperthyroidisms that are from an ectopic tissue. And so also knowing that there are these characteristics that are more important to understand, like thyroid storm or thyroid crisis. And I mentioned that earlier, right? So let's understand what that means. Now, though it's rare, it's very dangerous. And this is when you have patients that have had some type of infection or pulmonary cardiac disorder, trauma, even burns, seizures, surgery. Maybe they've had some type of obstetric complication, dialysis. There's a whole slew of things that can happen. But the symptom that you're most worried about is caused by that sudden release of increased action of thyroxine, which is T4, and triiodothyronine, which is T3. Okay, triiodothyronine. And this is going to exceed the metabolic demands. It's being released so rapidly. And the systemic symptoms of this crisis, you're going to have patients with hyperthermia, tachycardia, so everything is ramped up. You might even have atrial tachydysrhythmias. You might have high output heart failure, agitation, delirium, nausea, vomiting, diarrhea. And this is all going to contribute to fluid volume depletion. In order to fix this, you need to block the synthesis of thyroid hormone. And to do this, methimazole is a medication that can be given. You can also use beta blockers because of all the cardiac symptoms. You're trying to control and reduce those symptoms. You can give corticosteroids or even iodine as well. Radioactive iodine can treat hypothyroidism. And with radioactive iodine, this can shrink your thyroid and destroy the gland ultimately. And sometimes we need this. With Graves' disease, which is a hyperthyroid condition, in about 80% of all hyperthyroidism patients, this is what we would have. In approximately 3% of women and 0.5% of men in the US have Graves' disease. And we don't really know the cause, but there are some genetic factors in play. It's classified actually as an autoimmune disease, and it's from a type 2 hypersensitivity. So try to remember that. There's going to be the infiltration of lymphocytes and stimulation of the thyroid by autoantibodies that are detected against the TSH receptor. So these antibodies, which are called thyroid stimulating immunoglobulins, they are going to override the normal feedback mechanism. And this is what's causing this hyperproduction of thyroid hormone and then low production of TSH because of the negative feedback loop. There are two major distinguishing clinical manifestations of Graves' disease. You're going to see things in the eyes and the skin. You're going to have pre-tibial myxedema, and you're also going to have functional abnormalities that result from the hyperactivity of the sympathetic division of the autonomic nervous system. So what does that mean? You will see a lag of upward gaze of the eyes, or a lag of the upper lid with the downward gaze. You might also see an enlargement of the ocular muscles, which makes the changes of movement a little bit more difficult. And these changes affect more than half of the patients with Graves' disease. You might even have increased secretion of hyaluronic acid. You might have inflammation, edema of the orbital area. So that protrusion of the eyeball that you learned in health assessment, exophthalmos, that's the reason. You will also see preorbital edema, extraocular muscle weakness. It's going to also lead to double vision or diplopia and strabismus. So there's a bunch of different eye things associated with Graves' disease. Also, patients may complain of irritation, pain, photophobia, which is light sensitivity, blurred vision, a lacrimation, so tearing of the eyes, and overall decreased visual acuity. Smoking is going to exacerbate all of these symptoms. Some individuals, a smaller number of patients with Graves' disease and very high levels of thyroid stimulating hormones, are going to have pre-tibial myxedema. And this is characterized by subcutaneous swelling on the anterior portions of the legs. And you're going to have very indurated skin. It's going to look very red. And it's associated to thyrotropin receptor antigens on fibroblasts that are recruiting these T lymphocytes that will stimulate large amounts of hyaluronic acid production in the dermis and the subcutaneous tissue. So you might even see this on the hands, which is going to give the appearance of clubbing of the fingers. So hyaluronic acid, we like hyaluronic acid because it makes our skin look plump and new, but not in the case of Graves' disease. Again, we talked about the radioactive iodine ablation that can help if our patient's symptoms get too exacerbated and surgery is not an option, or you can also have the surgical removal of your thyroid gland as well. This slide here will help you to distinguish and differentiate between the differences of the clinical manifestations of hypothyroidism. You see everything with hypothyroidism, you have low, and hyper, you have an increase. So let's go with hypo first. You're going to have lower energy metabolism. So sometimes with hypothyroid patients, there's weight gain. They're going to have low heat production, so cold intolerance. They're going to feel lethargic. Their basal body temperature is lower. Remember, it's connected to myxedema, which is non-pitting edema, boggy edema of their eyes, hands, and feet. So you're going to see preorbital edema. Mucous membranes are thickened, so this is why they have more slurred speech, thick tongue, and hoarseness. In contrast with hyperthyroidism, you're going to have an increase in energy metabolism. So sometimes patients with hyperthyroidism, they actually lose weight. There's an increase in heat production, so they're very hot, not tolerant to heat. Their tissue will become more sensitive to the sympathetic nervous system. They may have a goiter. You might see those bulging bug eyes, so exophthalmos. And they also have myxedema, but it's pre-tibial myxedema only. Let's practice. There's 2 siblings diagnosed with thyroid disorder due to the destruction of thyroid tissue by lymphocytes circulating thyroid autoantibodies. What is this pathology most likely from? Well, hopefully you chose Hashimoto's disease, which is an autoimmune thyroiditis and a type of hypothyroidism. Lastly, under the thyroid disorders, I do want to talk about thyroid carcinoma. It's the most common endocrine malignancy. Most tumors are very well differentiated. You might have small nodules or metastatic tumors in the lungs, brain, or bone as well. With thyroid carcinoma, it does account for over 56,000 estimated new cases in the US, and it's the most common endocrine malignancy that constitutes less than 4% of all the neoplasms. Now, exposure to ionizing radiation during childhood is the most common factor. So when you are getting an x-ray, now you have that thyroid cover or thyroid shield. When you're getting x-rays on your teeth at the dentist, you have that thyroid shield. It's to prevent thyroid carcinomas. Most individuals with a thyroid carcinoma are going to present with normal T3 and T4 levels, and so therefore we call them euthyroid. So there's no changes, everything is normal. But the thyroid cancer typically is going to be discovered by the nodule first and then can metastasize. If you are able to figure this out soon, treatment for well-differentiated thyroid carcinomas is somewhat controversial though, because of its protracted nature and relatively low mortality. So some people think that they shouldn't do too much, and other people think that you should be very aggressive. Now, treatment of well-differentiated tumors can include surgical dissection. So it could be partial or total thyroidectomy. It could be radioactive iodine treatment as well. And then, of course, if you take away the thyroid, you're suppressing the hormone, and then you might have to replace then with thyroid hormone in lieu of the thyroid.
In this section, we're going to review alterations of parathyroid function. The parathyroid glands are usually 4 little glands situated on the posterior surface of the thyroid gland, sits behind the upper and lower poles of the thyroid. And they make parathyroid hormone, or PTH. And this is an important regulator of our serum calcium and phosphate levels in our body, which act on the bone, the kidney, and indirectly in the gut. Ultimately, we're trying to raise serum calcium. So whenever our body senses a decrease in calcium, PTH secretion will increase to help bring up the levels of calcium. Whenever our body senses that our phosphate is high, it will secrete PTH, and this will decrease the levels of phosphate in the plasma. Now, hyperparathyroidism is characterized by an inappropriately excess secretion of PTH by one or more of the parathyroid glands, and it would also cause hypercalcemia. And there's primary, secondary, and tertiary types of hyperthyroidism. When we have primary hyperthyroidism, we are again having this inappropriate excess secretion of PTH, and this in turn will trigger calcium to rise as well. 15% result from parathyroid hyperplasia, but up to 85% of the cases are actually caused by a parathyroid adenoma. We do have a genetic link as well. About 5% of the cases have to do with multiple endocrine neoplasia from the MEN1 and MEN2A genes. Now, in primary hyperthyroidism, the secretion of PTH is increased, and it's not under the usual feedback control mechanism. So there's a breakdown of that feedback loop. So the calcium level in the blood will start to increase because the increased bone reabsorption and GI absorption of calcium is occurring, but the failure is where it's not inhibiting PTH secretion at normal levels of calcium. That feedback threshold for calcium is set to higher level in abnormal parathyroid tissues. So it doesn't sense that there's too much. Now, hypercalcemia and hypophosphatemia are the hallmarks of primary hyperparathyroidism. So whenever you see calcium too high, expect phosphate to be low. Now, the effects of excessive PTH secretion and primary hyperparathyroidism and how it affects the organs are going to be summarized in the table in your textbook, and we'll look at them in just a second. Now, when you have secondary hyperparathyroidism, this is a compensatory response to the glands itself when there's chronic hypocalcemia. And this is a chronic complication of chronic kidney disease. When you have chronic kidney disease, you are not making enough calcium in the body, which will be detected in the serum blood levels. Okay, so not enough calcium in the serum blood levels, but you'll also have vitamin D deficiency as well with chronic kidney disease. And that secretion of PTH is elevated, but it can't achieve the normal calcium levels because there's an insufficient amount that's being activated because we have a deficiency of vitamin D. Now, there's other causes of secondary hyperparathyroidism as well, like if someone just has a chronic vitamin D deficiency that's not associated with chronic kidney disease, or if they have a calcium deficiency that's not associated with chronic kidney disease. Some people have decreased intestinal absorption of vitamin D or calcium, or the ingestion of other drugs such as phenytoin, phenobarbital, and certain laxatives will accelerate the metabolism of vitamin D in your body, or it can also decrease intestinal absorption of calcium. Finally, with tertiary hyperparathyroidism, this can actually develop after a long-standing period of hypocalcemia. And so say you have a patient that has had long-standing kidney disease and has chronic dialysis, or they've had a chronic problem with gastrointestinal malabsorption. Well, these patients have prolonged hypocalcemia, which will then cause the parathyroid chief cells to become hyperplasia. They will have hyperplasia of the chief cells, and this is going to lead to excess PTH production, too much. This is most commonly seen after someone's had a kidney transplant. After the correction of kidney failure by the transplant, the hypertrophied parathyroid tissue will continue to secrete and over-secrete parathyroid hormone. So what's the consequence of this? Your serum calcium levels will be normal or even elevated because of the hyperplastic glands. They're functioning autonomously despite the withdrawal of calcium and calcitriol. So we don't have that proper feedback loop mechanism. There are new drugs being used to inhibit the synthesis of PTH, but sometimes surgical removal of one or more of the parathyroid glands has to be completed if there's no response to medical treatment. There's one other thing worth mentioning, and it's familial hypocalciuric hypercalcemia. Sometimes it's called FHH. And this is a benign autosomal dominant condition. Sometimes it mimics hyperparathyroidism because you'll have high calcium levels and low phosphate levels, but you'll also have low urine calcium excretion. This is caused by a mutation of the calcium sensing receptor in the parathyroid gland, and the way that you differentiate this from primary hyperparathyroidism is by measuring the urine calcium excretion. So you'll get a 24-hour urine sample, and this will show that it'll be very, very low amounts of calcium excretion. You see on this chart the manifestations of primary hyperthyroidism. You can see the differences in the symptoms versus the mechanism causing the derangement. And so some patients with hyperparathyroidism, you see this hypercalciuria, right? A lot of calcium in the urine. Additionally, you'll see hyperphosphaturia, proximal renal tubular bicarbonate leaking, and a urine pH of over 6. This all has to do with the kidneys. What the patient will experience is renal colic, nephrolithiasis. Sometimes they'll have recurrent urinary tract infections, and ultimately renal failure can be a symptom as well. And this is caused by calcium phosphate salts that are precipitating, which will make the urine, it's precipitating because the urine is so alkaline. The renal pelvis and collecting ducts will also be affected with this precipitate, and oxalate stones can be formed. So too much calcium in the urine. Well, some patients will also complain of abdominal pain or peptic ulcer disease, and this has to do with the hypercalcemia that's stimulated by hypergastrinemia. And so what you're going to see is an elevation of hydrochloric acid secretions causing these symptoms. Well, some patients will have hyperparathyroidism due to the connection with pancreatitis, and that'll be the primary symptom. Pancreatitis is caused by hypercalcemia, but they don't really understand directly this etiology per se. But if you have a patient with pancreatitis and you notice that the calcium levels are high, then you might think that it's because of the parathyroid. Osteoporosis is commonly encountered, and now we understand that the disorders are more specific for hyperparathyroidism. So PTH is stimulating the bone reabsorption. Sometimes your patients will experience metabolic acidosis. So this is going to lead to ultimately bone disease. You might have osteotitis fibrosa, osteotitis cystica, and definitely osteoporosis because of this. You can continue looking on the chart for the manifestations, but I will just list them out. Go back and try to connect the mechanism and the derangements, but you'll also notice muscle weakness, myalgia, some neurologic and psychotic or psychiatric problems like memory loss, confusion, depression, anxiety, and even psychosis has to do with the hypercalcemia. We'll also have polyuria, polydipsia, constipation, anorexia, nausea, vomiting, hypertension because of plasma renin activity being elevated. Sometimes this is happening with renal disease, and the direct effect is going to be calcium on the arterial smooth muscles. Arthralgia and arthritis can also be seen, and this has to do with hyperuricemia, chronic renal failure that leads to high calcium phosphate. And so gout and pseudogout can often cause these arthritic pains in your patient. Now you're going to learn more in your MedSearch course about the evaluation and the treatment, but I'm just going to give you a limited understanding to help you to make some of the connections. Increased ionized calcium concentrations with elevated PTH concentrations are going to be suggested of primary hyperthyroidism, and so that's really the diagnosis there. And PTH levels may be inappropriate within a normal range because hypercalcemia should completely suppress PTH production. But sometimes there's asymptomatic individuals. Sometimes they're asymptomatic with mild hypercalcemia. And in this case, we would just observe. We would make sure that they aren't dehydrated and they're limiting their daily calcium intake. Definitive treatment of patients with severe primary hyperthyroidism will include surgical removal. If it's an adenoma that's causing it, they take out the adenoma. But in the case of hyperplasia, you might have to completely remove the glands. And imaging can help you to understand if it is an adenoma, where it's localized before the surgery. And of course, if your patient fails surgery, other treatments like providing biphosphonates and calcium mimetics, which will mimic the calcium, this can be considered as well, because if you remove the parathyroid, then you are losing the production of, or the stimulation of the production of calcium. And so that the calcium mimetics will increase the parathyroid calcium receptor sensitivity. And by doing this, you can lower PTH levels. And so if surgery doesn't work, this is a consideration. And now I talked about really briefly familial hypocalciuric hypercalcemia. Remembering that this is a benign autosomal dominant condition, for most of the patients that will appear to have primary hyperparathyroidism, but in terms of it not being that and it's FHH instead, these patients are mostly asymptomatic, and so it's something to consider if they are asymptomatic. And again, you're looking for possible kidney stones from the hypercalciuria. Their urine will be very alkaline, and you might even have symptoms that are leading to pathologic fractures as well. Now, secondary manifestations may lead to low serum calcium but an elevated PTH. And so surgery, biphosphonates, corticosteroids, and calcium mimetics are what would help the patient with familial hypocalciuric hypercalcemia. Now we'll talk about hypoparathyroidism, which is abnormally low PTH levels. And the most common cause is damage to the glands themselves, or the removal of the parathyroid gland during a thyroid surgery. And this can happen because they are so close to each other anatomically. But also, maybe you've had a hyperparathyroid patient that now, because of surgery, they're a hypoparathyroid patient because you've taken out maybe the adenoma, or you've had to remove the entire gland. There's also some associations with genetic syndromes as well that would cause hypoparathyroidism. In addition to having low PTH levels, hypomagnesemia, or low magnesium, can cause a decrease in PTH as well, in both the secretion of PTH and the function of PTH. There's also an inherited condition that's associated with hypocalcemia, but you would also have normal to elevated levels of PTH. And this is called a pseudo-hypoparathyroidism because the PTH levels aren't really low, but it's the calcium levels that are low. Now, these patients, if they have this form of the condition, they're going to be resistant to PTH in the proximal renal tubule. So they can't produce the response in that post receptor. And so when they do have the PTH in their body, it's not going to respond by elevating the calcium like it should. So in terms of pathophysiology, this lack of circulating PTH is going to depress your serum calcium levels. In reverse, or an inverse relationship, it's going to increase your serum phosphate level. So remember, whatever calcium is doing, phosphate is doing the opposite. In the absence of PTH, the reabsorption of calcium from the bone and the regulation of calcium reabsorption from the renal tubules, this is going to be impaired because it needs PTH to signal to let them know what to do. So phosphate reabsorption by the renal tubules will be increased, which will cause a decrease in renal phosphate excretion. Because of this, because it's not excreting phosphate, you're going to have hyperphosphatemia. So again, if phosphate is high, serum calcium is going to do the opposite. So it will be depressed. I talked about magnesium and its connection. When you have low magnesium or hypomagnesemia, this will inhibit PTH secretion. When serum magnesium levels return to normal, however, this secretion will also return to normal. It's directly connected. And therefore, the responsiveness of the peripheral tissues to PTH will also go back to normal. Well, why would someone have hypomagnesemia in the first place? Think about patients with nutritional deficiencies, malabsorption of magnesium, or chronic alcoholism. This could cause chronic low magnesium. Patients with increased renal clearance of magnesium caused by the use of an aminoglycoside antibiotic or chemotherapy agents. This can also decrease magnesium as well. Now, the clinical manifestations of someone with hypoparathyroidism will be hypocalcemia because of the low PTH production. Additionally, hypocalcemia will cause a lower threshold for nerve and muscle excitation, so that nerve impulse may be initiated by a slight stimulus. So anything that can stimulate the nerve for it to trigger, it really doesn't take much in this situation. So what patients will ultimately experience is perioral numbness, paresthesia. Normally there's tingling. They may have tetany that's caused by muscle spasms. Their reflexes become very hyperreflexive. Some patients with low calcium will also have tonic-clonic convulsions, laryngeal spasms as well. And in severe cases, because of the laryngeal spasms, they could also experience death from asphyxiation. Remembering from health assessment, you may have talked about Chopstick sign, which is elicited by tapping the cheek right near the zygomatic bone, and this is going to result in twitching of the upper lip. Trousseau's also can be evaluated for neuromuscular irritability, and Trousseau sign is elicited by sustaining inflation of the sphygmomanometer, so the blood pressure cuff. You place it on the upper arm to the level above their systolic blood pressure, and you hold it there, and your patient will experience very painful carpal spasms. This also lets you know, and it signifies that there are low levels of calcium. And other symptoms of hypocalcemia will include dry skin, dry scalp hair, loss of body and scalp hair, hypoplasia of the teeth that may develop. Horizontal ridges on their nails can also be seen. Some patients will experience cataracts, and they may even have basal ganglia calcifications. And when you see this, this is actually associated with Parkinsonian syndrome as well. Other things like bone deformities and brachydactyly will be seen also, and maybe you'll experience bowing of the long bones as well. because your calcium levels are so low, there's going to be high levels of phosphate and your body can't regulate that. And so there may be phosphate retention. The treatment is to replace the low calcium levels with calcium and vitamin D, and you might need to also provide phosphate binders because there's so much phosphate circulating within the body. So let's practice. Which information is correct regarding hyperparathyroidism? Hyperparathyroidism is associated with, here the answer is A, pathologic fractures. When you have excessive osteoclastic and osteocytic activity with hyperparathyroidism, this is going to result in bone reabsorption that can cause pathologic fractures. You might even have patients with kyphosis of the dorsal spine. Compression fractures of the vertebral bodies can also happen as well.